Patient Saidati, 53-year-old female resident of Pastur district, Hep C positive from the last 5 months. On direct antiviral agent presents with a previous episodes of hematemesis and angina, hemoglobin 9.1, platelet 119, ultrasound post-cirrhotic given in splenomegaly, endoscopy done on February 8, low esophageal varices, GOG1 and fundal varix.
Hello everyone. Hello everyone. Can you listen me?
So please move the mic a little bit.
Can you hear me, please?
Yes, sir.
So this middle-aged lady has hepatitis C related chronic liver disease. Child C presents with upper GI bleed. And in the previous reporting it was told that there is no esophageal varices and there is isolated gastric varix 1. But there are small size esophageal varices, though there are no signs of, there are no red signs. And you can see there are small size varices, grade 1 to 2. And if you go into the stomach, you need to classify the varices as per Saran classification, Serene classification, where it may be gastroesophageal varices 1 if it is going esophageal varices along with gastric varices if the extension is along the lesser curve, or GOV2 like in this case where there is fundal varix along the greater curve. And it may be isolated gastric varix where there is no varices in the esophagus and only gastric varices along the fundus, or IGV2 where the varices are present elsewhere in the stomach, maybe in the mid body or in the antrum. So if you see the varix, you can see a stigmata of recent bleed, you can see some discoloration, you can say punctum at this point, and you need to see the size of the varix because the volume to be injected depends on the size. Though most of the literature says at one time you should be injecting aliquots of 1 ml, and you can always re-inject, but it will be needing maybe needing more needles because there are pros and cons of both approaches. If we inject little more like 1.5, like in this case, there may be some increased risk of embolism. But if we safe is to inject with 1 ml aliquot and reprobe, touch with the probe, palpate the varix. If there is soft area, you can always re-inject. And then there is some discussion about the point where it needs to be injected. You can inject on this maximum bulging part, and you can be injecting here where there's a feeder vessel. What is the opinion of the house? Should we be injecting on the maximum bulging part, or where the feeder vessel is coming? What is the opinion of the house?
Sir, please comment.
Now, this is a very unusual feeder and it looks like a feeding vessel.
Yeah.
So there is an option of injecting in this. Don't you think maybe EUS examination is more helpful in that, because that gives you a clear idea of from where the circulation is coming? So what are you going to decide now? Is it the feeding vessel or right at the apex?
If the EUS is available, it can be helpful because in the real time we can see the obliteration of the varix, and if we can always inject some coils that decrease the volume needed for obliteration of the varix, and so there is less chances of embolism, and in real time you can obliterate the varix, and you can find the feeding vessel with more confidence. And if we inject the feeder vessel, the volume to be injected will be further lowered. But given the EUS is not available, I may be injecting in the most prominent part, or where the feeder vessel is coming into this varix.
But you will be injecting into the varix, adjacent to the feeding
Yeah.
vessel. That is what you are saying?
Yeah.
Not in the feeding vessel, but
I will be
in the main
close.
varix adjacent to the feeding
Yeah.
vessel. Yes. At the base, not at the apex.
Yeah. So what is the opinion of the house? What should be the volume we be injecting? Most of the literature is you inject 1 ml, again repalpate the varix and re-inject. So should we be injecting 1 ml or 1.5 ml in this case?
The visual impression says that 1 ml may be inadequate. Professor Maswani.
We had a similar case where I was in Florida. The consensus there was that you should always inject the feeding vessels, not the main one,
Yeah.
and do not inject more than 1 cc at
Yeah.
one time, and always link it with a coil, because coil kind of binds the histoacryl cyanoacrylate and it doesn't migrate. And in their review, they found out that about 40% of these people, when they followed with the CT angiogram, they had pulmonary emboli. So it's a very high risk of, if you inject more, high risk of getting emboli. So the idea of putting coils is that it doesn't migrate, less chances of emboli, and you inject small quantity that binds to the coils. And then you can come back and palpate. You don't have to do it all at one sitting. You can always come back and palpate, see which is solid area. You don't deal with it. If it's a softer area, you inject 1 cc again with a coil. So that was the consensus there.
So asymptomatic emboli may be quite common, especially if we are using with a mixture of Lapardal or other like olive oil or vitamin D, because it delays the polymerization time. Two types of preparation we have. One is N-butyl cyanoacrylate, which has a polymerization time is around 5 seconds, and other is 2-octyl cyanoacrylate, which comes with the name of Dermabond. Derma people use it for the closure of skin wounds, and it has a polymerization time of more than 10 seconds. Both can be used, but in today we are going to go with N-butyl cyanoacrylate, and we are injecting pure injection without any dilution, because most of the data is there's no need to dilute it with the Lapardal or other carrier like olive oil. Recent AGA guidelines also concluded there is no need to dilute. Dilution was meant to delay the polymerization with N-butyl cyanoacrylate, to avoid polymerization in early polymerization in the needle, and because it's radiopaque, you can follow fluoroscopically with the obliteration of the varix. And then you can always, if you do access in such cases, you can always find asymptomatic small emboli, but the patient are asymptomatic.
Dr. Shafqat, are you going to prime your needle beforehand? And what are you using for priming if you are doing it?
Yeah,
and
before
what we will be injecting afterwards, after this tracker, to extrude the gel in the channel.
Before proceeding with the histoacryl injection, it's very important that you do a drill, especially if your tech is the one you are not doing your daily procedures, because you are tuned with your tech. If the tech is new, I already before we have a meeting, before I did endoscopy, I checked the needle. 21 gauge needle is the go-to needle, and ideally we should be wearing goggles, because in the advent of some spillage, it can cause significant damage. And for pushing purpose, and we should always have extra needles. We should always have extra histoacryl, because there may be a continued bleeding and we may need to re-inject. So we did a drill. I told her to prepare the multiple injections, fill it histoacryl, and then the pusher for pushing purpose. And for pushing, the solution to be used is distilled water, not normal saline, because normal saline accelerates the polymerization of histoacryl. And then we are putting in.
Dr. Shafqat, can you hear? थोड़ा सा अपना mic adjust.
Can you hear?
Yes, now it's okay.
Okay. So all the instrumentation should be done with a straight scope. So the scope is now straight. Our needle is out, and then we move to the varix, toward the fundus. पकड़े यहाँ पे रखें. So if the patient is already injected, it's always better to palpate the varix and to see the trajectory of needle, where it's going. So I will be injecting into the feeder vessel. पकड़े यहाँ पे.
Any precaution to avoid scope damage or in this situation when it's very close to the scope as well?
If you're injecting in, you should not be doing suction while injecting, because it can always block your channel. Yeah, okay. जी, needle out. जी, inject. जी, जी.
Tuck the sheet against the varix and then needle out, or
Push with distilled water. जी, जी. Again, push in. हाँ जी, देखो. You should not be doing suction, rather flushing.
Dr. Shafqat, the question is, do you use separate needles each time you inject, or you reuse?
You can use the same needle if it's patent. देखें,
So
needle देखें.
you will check it. If it is
Yeah.
okay, then you will.
नहीं नहीं वैसे वो करें ना. Clogged.
Block.
So the needle is clogged, so we cannot use this needle again. So we'll be coming out with the needle.
So you see that Shafqat is taking out the scope along with the needle and not pulling the needle out of the channel to avoid any soiling of the channel with it.